So good afternoon. It's not working. So I think we'd all agree that with this survey by Dr. Takish, that the retracted subscap tears are, I think, the most challenging arthroscopic part of rotator cuff repair. And it needs a lot of experience in order to be able to identify the tear, to be able to release it, and to repair it back into place. It is a hidden lesion. Most of the subscap tears are, most of the subscap tears are like small pasta tears. Here we go. Are small tears that would require, there's something wrong with the videos, but it's okay. We're all running concomitant things. Just hold on. Okay, I'll skip this slide. So with the incidence of subscap tears, isolated subscap tears aren't really that common. I don't think we see them that much. Reports are around 5%. I think they're lower. But combined subscap with supraspinatus tears are very common. They're around 30% across literature. So if you don't see that much subscaps with your rotator cuff tear, you're probably missing them. You should see one in around 4 or 5. You know the classification, Dr. Lafosse classification, he classifies them into partial rupture tears or like pasta tears. Then you got the upper 1/4, upper 1/2, and then a bigger tear than that. You should be able to recognize them first of all, and you need to repair them because the subscap is very important in force coupling of the shoulder to balance the anterior and posterior forces and to allow proper shoulder function. The common sign is when you got a retracted tear, the medial stabilizers of the biceps, the coracohumeral ligament, the superior glenohumeral ligament are retracted and they curl around the retracted subscap, so you should be able to identify them as well during surgery. How do I suspect subscap tears? I usually suspect them clinically when I have a significant functional impairment, so the patient has a small supraspinatus tear, but he's not doing well. He has severe pain, severe functional impairment. I do suspect that there is a subscap tear as well that is not balancing the shoulder. And your examination should always include a specific test for the subscap. What I personally use is the bear hug test. I find it very specific. And you should ask the patient, where is the pain while he's doing the test? It might not only be weakness, it could be pain as well. And he will point around this area. So you should be careful about it. MRIs, well, to be honest, you can only see subscap tears on the MRI if they are large tears. The tears that we usually find, the smaller tears, it's very difficult to detect on MRI. The sensitivity is around 40%. Dr. Adams came up with this 4 criteria approach where he looked at axial and sagittal images. And if you got 2 of the 4, then you should suspect a tear. It didn't help me that much, but it is out there. Whenever I find an anterosuperior cuff tear, a tear involving the anterior pillar of the cuff, I always suspect that there is an upper subscap tear as well. So this should be an alarming sign. How I do it is I do my cuff surgery in the B-chair position. To do a subscap repair, you need 3 portals, a classic posterior portal, high. Then you need an anterior portal and another anterolateral portal that is done under visualization over the upper border of the subscap. If you have a sentinel sign, which is fraying in the undersurface of the biceps, you should suspect that it's rubbing against a torn subscap and there is a subscap tear there. I always do subpectinodesis if I need, so I tenotomize the biceps from the start. It gives me more space to clear up the rotator interval and makes my repair easier. After doing the tenotomy, I do extensive capsular release. This is very important. You must be able to visualize very well. The limit of your release is not, you don't want to go medial to the coracoid. You can go as much medial between the subscap and the glenoid. This release should be done thoroughly. Take your time. Should be able to release, identify first, release second, and to be able to see the sutures of the anchor easily. This is very important. The release part is what makes the surgery much more easier. The release should be could continue it all the way to the lateral part of the tear. You should release the footprint as well. Sometimes there's a lot of fibrous tissue. Be a little bit aggressive and don't worry about it. Then I do an anterolateral porter, which is at the upper border of the subscap, going from lateral. This is a very important portal for me. It allows me to finish my release, prepare the bed, shuttle the sutures, and sometimes to insert my cannulas. But you need two working portals to be able to do a subscap repair in an easy fashion. Then I start preparing the bed using a motorized shaver and a rasp. You should be able to see it clearly. Doing internal rotation and pushing back on the arm is a helpful way to look at the bed. And then I check the reduction. I usually put in a traction suture, make sure that I can get my subscap back to the bed easily. If I need to do more release, I will release more. But it's very important to take your time in the last few steps. Inserting the anchor. You can insert the anchor through either the anterior portal or the anterolateral portal. You can use either. If you're going to use the anterior portal, your hand has to be upwards and towards the nose or the jaw of the patient to avoid penetrating into the joint. So I use both, but right now I usually use the anterolateral portal. It's much easier for anchor insertion, and I then don't have to pull my sutures back again into anterolateral portal. They're already there. It makes shuttling much easier. I use usually a modified Mason Allen stitch with a double loaded anchor where I pass two limbs in a matrix fashion and one other limb of the remaining suture medial to the first two. It gives me a ripstop effect with a compression effect as well. And this is, I usually use one anchor, very rarely that I need two. And then you need to check your repair after you finish. And if you follow these steps, it should be much easier. I do most of my repairs intra-articular from inside, but some people can do it from outside the box, especially our friend colleagues. A question to be asked is, do we need to do a coracoplasty like we do an acromioplasty? Well, they say that the normal coracohumeral distance is around 11 millimeters. If it's less than that, then you should resect part of the coracoid. Well, actually, it's not usually the case because sometimes the head is subluxed a little bit anterior when the subscap is torn. So when you repair it back into place, it's already going to go back to position and the space will return back to normal. So most of the time, I think most of us don't do this coracoplasty. I think I've never done it with a subscap repair, and I do quite a few. You can do your repair from outside the box as well. I don't usually do it, but sometimes if you got a massive tear, it is an option. Once again, you check after you release, make sure that you can bring it back into place. We're looking from the lateral portal. This is a right shoulder. After doing your releases and preparing the bed, you put in your anchor while looking from the lateral portal. It's another easy way for doing it. I don't see that I need it every single time, but sometimes if you have a massive cuff repair, this space is open, so you might do it as well. It might be easier to do it this way. And I pass the same kind of sutures. and check my repair at the end. What I sometimes do nowadays is when you got a massive traumatic tear and the whole cuff is sleeved off the head, the supra, the infra, and the sub all go off in one single bulk. I usually preserve the coracohumeral ligament, which is at the lateral attachment of the subscap, because it helps me with the retraction of the supraspinatus. It brings it back into place. So this is a massive tear. As you can see, identification sometimes is difficult. How I do it is first I reach the coracoid. As you can see, I'm pushing on the coracohumeral ligament, the lateral part of the subscap. I keep it in place. Then I do my release. This is the lateral part of the subscap. I keep it in place. Sometimes it's difficult to work around it, but it will help you at the end. Then I pass a traction suture, check my release again. I might need a little bit more. We're under slight tension. This is the midglenohumeral ligament. We've released it. Appears from the back of the glenoid. I release it as well because it might be a tether to external rotation. I prepare the bed while keeping the coracohumeral ligament. Insert my anchor through the anterolateral portal. Pass my sutures in the same fashion, but here, the last suture, I will pass it through the lateral coracohumeral ligament to fix it into place. And as you can see, good repair, and I preserved the coracohumeral ligament, so it will pull my supraspinatus back just above the footprint. So my take-home message is always suspect a subscap tear, especially with anterosuperior tears. The most important step is to do an anterolateral portal and to do a proper interval release, starting from the coracoid and moving lateral. If you cannot see a tear, do an internal rotation with posterior pushback and check if the footprint is bare. And please do it one step at a time. If you skip steps, it's going to be a much more difficult procedure. But if you don't skip steps, it will be much more easy. Thank you.